هلا اذا الدكتور محمد عزام جاهز وموجود. دكتور محمد عزام اخصائي صدريه والعنايه الحثيثه في سانت مايكل سيتن هول يونيفرسيتي في نيو جيرسي. دكتور محمد عزام راح يعطينا محاضرتين. الاولى حتكون introduction to shock والمحاضره الثانيه حتكون عن sepsis and septic shock. تفضل دكتور محمد.
بسم الله الرحمن الرحيم. بحب أشكر زملائي بالحضور على الجهود المبذولة لليوم، وإن شاء الله يكون بعون الجميع والله يشفي مرضى الأردن. إن شاء الله اليوم I'm going to talk about two topics. أول واحد shock و the second one will be إن شاء الله about sepsis. الصوت واضح أول شيء عشان أتأكد بس.
واضح.
ممتاز. Again أنا دكتور محمد عزام وراح نبدأ بأول موضوع اللي هو shock. Shock, as we know, is a life-threatening condition with circulatory failure. It's a state of cellular and tissue hypoxia due to reduced oxygen delivery, increased oxygen consumption, or inadequate oxygen utilization. هلا بالنسبة للشوك there are multiple phases. Phase 1 which is more like compensated with maintained organ function. إذا ما بتعالج بأولها راح يصير more uncompensated, more organ dysfunction, renal failure, heart failure, liver failure, more abnormal vital signs, واللاكتيك acid راح يبدأ يزيد حتى يوصل لphase 3 which will be more multi-organ failure which will lead to death. هلا بحب احكي اول شيء بعض النقاط على الفسيولوجيكال كونسبتس بالشوك. الاكسجين ديليفري which is كميه الاكسجين اللي راح تنتقل للتيشو بير مينيت. كميه الاكسجين consumption which is the amount of the oxygen removed from the blood to the tissue. والاكسجين extraction ratio which is the ratio of the oxygen consumption للاكسجين ديليفري. هلا بالنسبه للاكسجين اكستراكشن ريشيو نورمالي اللي قاعد ما في عنده مشكله تقريبا 25%. لما واحد بيبدا يلعب رياضه الاكسجين ريشيو will increase وممكن توصل ل 65 to 70% especially بالاثليتيك person. كيف بنحسب الاكسجين ديليفري والاكسجين كونسامشن؟ بنضرب الكاردياك اوتبوت بالارتيريال كونتنت تاع الاكسجين وهذا بيعطينا الاكسجين ديليفري which normally it's about 1000 ml per minute. الاكسجين consumption هو عباره عن الكاردياك اوتبوت multiplied by الديفرنس بالارتيريال والفينس كونتنت. والاكسجين اكستراكشن ريشيو هي عباره عن الريشيو للاكسجين consumption divided by oxygen delivery. هلا how to understand this in real life. هلا as we know as metabolic demand increase or oxygen delivery diminish, the oxygen extraction ratio rise to maintain aerobic metabolism and consumption remain independent of delivery. فطول ما انت بتبدا تلعب رياضه راح يكون at certain point في maintenance وبالانس او ببدايه السبسز راح يضل في maintenance وبالانس. بس المشكله وين بتصير؟ لما نشوف على الاكس اكسس هنا حوالين المية عند الاكسجين ديليفري راح يصير عندنا نقطه اسمها critical oxygen delivery اللي هي اذا الاكسجين ديليفري بينزل اقل من 100 او الاكسجين كونسامشن راح يزيد، راح يبدا المشكله اللي هي عباره عن increase بالانيروبيك ميتابوليزم وانكريز باللاكتيك اسيد. فهنا بدايه المشكله بالنسبه لللاكتيك اسيديميا worsening deterioration. هلا as we know there are multiple types of shock. The most common is the distributive shock, which is account for about 66% of the shock. There's a cardiogenic shock, which is account for about 16%, and hypovolemic shock 16%, with obstructive shock about 2%. It is very important to understand the definitions and the types of these shock. لأنه لما نيجي نعالج المرضى each type of shock is a little bit different. فإذا بدنا نحكي على الكارديوجينيك شوك. كارديوجينيك شوك مثل ما حكينا 16% تقريبا، يا انه المريض عنده البامب مش شغاله secondary to either ischemia مثل having a heart attack, or non-ischemic cardiomyopathy can be from like severe alcoholic consumption or viral infection. هلا إذا المريض عنده الإسكيميا بده نحكي للأخصائي القلب إنه يوديه لل cardiac catheterization ويعمل له revascularization, try to improve الأكسجين أو blood flow بالهارت. إذا المريض عنده valve problem, severe regurgitation, stenosis, special stenosis, he would need evaluation repair or replacement. إذا المريض عنده severe arrhythmias مثل نحكي atrial fibrillation with rapid ventricular response أو SVT, he will need a synchronized cardioversion. أو إذا المريض ب VFib بده شوك عشان نحاول نرجع الرhythm للنورمال. إذا المريض هلا بالنسبة للdistributive shock, الdistributive shock as we know it is the most common, وحوالين 62% من هدول الشوك are secondary to sepsis. عشان هيك it's very important to recognize this type or early management, mainly antibiotic fluid, as we'll be talking about it in the next lecture إن شاء الله. بالنسبة إذا المريض نحكي he had a bee sting or has anaphylactic reaction, IgE mediated shock, he will need like emergent epinephrine injection. Is a type of shock secondary to severe adrenal insufficiency. He will need hydrocortisone. إذا المريض عنده severe inflammation as like pancreatitis, supportive treatment. إذا المريض عنده neurogenic shock secondary نحكي ل severe trauma, brain injury causing also cord injury, راح يصير عندنا autonomic dysfunction وبالتالي vasodilation و cause the shock. إذا المريض type of shock عنده hypovolemic مثل مريض جاينا ب severe bleeding either من الجهاز الهضمي أو من أي سبب تاني بده massive blood transfusions. إذا المريض عنده severe gastroenteritis, he will need fluid resuscitation. بالنسبة للobstructive shock, إذا المريض عنده massive pulmonary embolism, التريتمنت هون راح تكون give him a TPA. إذا المريض عنده tension pneumothorax نعمل كنا procedure بعدين صار tension pneumo or even spontaneous, he will need a catheter to be placed to let the air come out, or chest tube. إذا المريض عنده pericardial tamponade, try to drain this fluid around or blood around the heart to restore good contractility and diastolic dysfunction for the heart. إذا المريض نحكي جانا بعد surgery عنده abdominal compartment syndrome, نفحص الابdomen very distended, firm. We should be recalling the surgeon for further evaluation. Also, we should be checking the intra-abdominal pressure. If it's more than 20, a surgeon has to take him back the surgery to keep the abdomen open and reevaluate what's going on exactly. I'm losing the control on the chart. Hello?
دكتور محمد اعمل next من الكيبورد.
Even I'm not able to. Okay, let's see. Okay, now it's working. Okay, so as we spoke about distributive shock, we already said that it's vasodilatory, decrease in the systemic vascular resistance, and on exam it will be more perfused warm shock. Now the other one, the cardiogenic shock, on exam the patient will be more like cold, clammy, on exam having murmur, chest x-ray may have pulmonary edema, abnormal EKG, or having elevated cardiac enzymes. In obstructive shock, as we spoke about it, and here on a quick x-ray, we are having a tension pneumothorax on the right side of the lung. We see how the everything, the mediastinum is shifted to the left side, and the treatment by putting a chest tube. Again, here we have a CAT scan which is showing massive pulmonary embolism. We see how much it's extensive, and we should be treating it with emergent like TPA and shock status. Now, approach for a patient who's coming to us with shock. History and physical exam is very important in any patient coming to us. Again, is the patient having symptoms and signs of having fever, infection, leading to like a septic shock, or is the patient having symptoms of chest pain, difficulty of breathing, leading us to like possible cardiogenic shock, or is the patient having like GI bleeding, that we'll start to think about GI bleed and so forth. Again, make sure we always examine the patient from head to toe. Remember, we have to review closely the vital signs, listen to the chest, murmurs, rales, bronchi, make sure that there are no abdominal tenderness, and so forth. We start with the routine blood workup as diagnostic workup, CBC, complete metabolic panel, lactic acid, troponins, BNP, image study to be directed as needed, trying to see the source of the infection. Echocardiogram, now what we are doing is the standard care is do a quick bedside ultrasound, which is a very helpful and useful tool. Using the ultrasound, we can check the contractility of the heart, the valves, make sure no ما في كمان pericardial tamponade. We can do a quick lung exam, make sure that the pleura is sliding, so there are no like pneumothorax. Make sure that we can check the inferior vena cava and see the variability. Does the patient need more fluid? We can do a quick abdominal ultrasound as well, make sure that there's no bleed there, and also take a look on the vascular, make sure that the patient is not having, deep vein thrombosis, let's say in the lower extremity. So bedside ultrasound, again, is very, very helpful tool. And meanwhile, also we'll continue to monitor the patient continuously for the hemodynamics. Invasive hemodynamic monitor, again, they used to do like triple lumen catheter or pulmonary artery catheter on almost every patient. The triple lumen, like subclavian or IJ, give us idea about central venous pressure and mixed venous blood gas. But again, we know that the central venous pressure is inaccurate number for the real volume of the intravascular. So even if the number, let's say it's 5, that does not mean that the patient still needs fluid. And we'll be talking more about it in the next slide, inshallah. Mixed venous blood gas is very important. If you are using inotropic agent, it's helpful to titrate again your dose of the pressors. And the pulmonary artery catheter will be the Swan catheter, in other words. We'll be talking about it here. So there was a meta-analysis regarding the pulmonary artery catheter, the Swan. 13 studies review concluded that the use of pulmonary arterial catheter did not alter the mortality or having any benefit. So that's why it's discouraged to be used. Again, normal parameters. So the Swan catheter, systolic blood pressure, 90 to 130, diastolic 60 to 80, right atrial pressure less than 8, right ventricular pressure, systolic about 15 to 30, diastolic about 5, pulmonary arterial pressure, systolic 15 to 30, diastolic 9 to 6, wedge pressure less than 12, cardiac output about 4 to 8 liters, and cardiac index about 2.4 to 4 liters per minute squared meter. This table is very important to understand. So to really differentiate and approach the patient. So all of them are having low blood pressure. But let's say in septic shock, what's going on? The systemic venous resistance is decreased, which means the cardiac output, left ventricle will be having more a hyperdynamic contractility, try to compensate for that. And this will lead to like a normal or high cardiac output. The wedge pressure, the right atrial pressure will be normal or low. Now, for cardiac shock, again, the pump is not functioning well. So the cardiac output is low. The systemic vascular resistance is trying to compensate for that. And the right atrial and the wedge pressure, because of the heart failure, there will be elevated. In obstructive shock as pulmonary embolism, the pulmonary vascular resistance is high, and this will lead to decreased cardiac output, low wedge pressure, but elevated right atrial pressure. In hypovolemia, the patient already losing the fluid or the blood, while cardiac output is low, with systemic vascular resistance is trying to compensate for that by constricting, and it will increase the right atrial and wedge pressure will be low. So a quick question, a 60-year-old female with acute MI, ST elevation, parameters, again, systolic blood pressure 82/50, right atrial pressure is 20, right ventricular pressure 30/20, pulmonary artery pressure 30/18, and the wedge pressure is 19. Cardiac index 2.2. So what's going on here? So is it ruptured mitral papillary muscle, VSD, pericardial tamponade, right ventricle infarction, or pulmonary embolism? So looking again back here, we can see that we have equalization of the pressures in the right atrial pressure, the wedge pressure, and the diastolic pressure. And this would be consistent with pericardial tamponade, and the treatment will be here a pericardiocentesis. Another question, a 60-year-old man with acute MI, ST elevations again, having murmur. Now the systolic blood pressure 80/40, right atrial pressure is 10, and right ventricular pressure 50/10, pulmonary arterial pressure 50/30, wedge pressure 26, cardiac index 1.6. But looking now here at the saturation, we have pulse ox of 97%, and right atrial pressure 48, right ventricular saturation 64, and the pulmonary artery oxygen is 62. What happened? We can see that there was a step up in the oxygen saturation from right atrial to right ventricle, which means that there is a VSD, and we should be calling like a cardiothoracic evaluation. Initial management of the patient with shock. Again, rapid clinical evaluation focusing on the likely cause as we spoke. Make sure the patient is having airway, breathing, circulation. If he's hypoxic, give him supplemental oxygen. If he is in severe distress, hypotensive, encephalopathic, not able to maintain his airway, protect his airway, intubation. Make sure you are working early on reverse and control a source of shock because this will be the ideal treatment. Restore adequate circulation. So if the patient is hypovolemic, make sure that he's getting fluid, blood as needed, resuscitation, pressors to keep mean arterial pressure 65 to 70. And as we spoke, the bedside ultrasound is a very helpful tool. Prevent and reduce organ injury and dysfunction. Try to go from phase 2 to phase 3. And make sure that you are not getting also side effect of the way that you are trying to give a side effect of the medication, or even contrast of the images that we are ordering. So fluid-wise, the fundamental reason for giving fluid in resuscitating a patient with shock, is it increased blood pressure, increased intravascular volume, increased mean systemic filling pressure, or increased stroke volume? So the answer would be increased stroke volume, as we will see here. So fluid optimization concept based on stroke volume. As we remember from Frank starting low state, that the stroke volume of the left ventricle will increase as the left ventricular volume increases due to myocyte stretch, causing a more forceful systolic contraction. وهذا راح نشوفه على الكيرف واحنا طالعين عبين ما نصير عنا البلاتو. لما يصير البلاتو already المايوسايتس already stretched وما راح يقدروا يعملوا more contraction وما راح يقدروا يزيدوا الستروك فوليوم والكاردياك output. And this is very important to understand, لأنه لما نصير نحكي على الميجرمنت اللي راح نعملها والتولز اللي راح نستعملها to check the variability, we are looking for variability about 10% or 13%, and if these variables are more than 10 to 13%, that means that we are still on the curve and the patient will get benefits from fluid resuscitation. بس لما يصير variability less than 10%, that means we are almost at the plateau and that patient will not need any more fluid. Otherwise, it will even cause more worse outcome. الطريقة اللي بنعطي الفلويد it has to be as like Willis is about 250 ml and re-evaluate. Again, use fluid as medication, treat symptomatic hypovolemia, maintenance fluid. We have limited role in ICU, try to avoid fluid overload, worsening ARDS, worsening third spacing, all these things. Management of fluid. We have the crystalloid, the colloid, and blood. So the crystalloid, we have the normal saline, which is 154 sodium, 154 chloride, with osmolarity about 308. We have the more balanced fluid, the plasmolite, ringer lactate. They have less sodium, less chloride, but also they have some potassium in them. On the colloid side, we have the albumin and we have the hydroxyethyl starch. HydroxyEthyl starch outcome, don't ever use it because it increases the mortality rate with renal failure. هلا بالنسبة للstudy by Perner and his colleague بال New England Journal, what to use crystalloid or hydroxyethyl starch, as we see إنه بالنسبة للأرم اللي كان فيها الهيدروكسيethyl starch, the number of deaths with dialysis patients were higher 51% compared to 43% with p-value of 0.03. واحنا بنقدر كمان نشوفه هنا انه الرينجر لاكتيت كان was having better survival compared to the HES, and that's why we should not be using HES. هلا بالنسبة للكريستالويد versus the albumin, we have the SAFE trial in the New England Journal. Again, it was having 6,997 patients, albumin versus saline, no change in mortality, length of stay, mechanical ventilation, or renal replacement therapy. There is the Albius trial also, which was having 1,800 patients, septic patient. Again, no change in mortality. We can see that on the curve here, albumin versus crystalloid with survival with P ratio of 0.39. طب السؤال بيجي مين نستعمل النورمال سالين ولا اللاكتيت رينجر او بلازما لايت؟ البottom line انه there is no conclusion or firm data to use this and not use the other one. But in normal saline has higher rate of some kidney side effect with 15.4% compared to 14.3 على البالانسد crystalloid, and the P ratio was 0.04. بس هذا مش معناته انه ما نستعمل النورمال سالين اذا اللاكتيت رينجر مش موجود او البلازمولايت مش موجود، او حتى كاسعار انه البلازمولايت والرينجر لاكتيت كثير اغلى من النورمال سالين. فشو you can use either one. المورتاليتي were تقريبا مثل بعض. بالنسبة للسبتيك شوك, crystalloid initial fluid of choice, chloride poor solution, LR associated with less acute renal failure, renal replacement therapy, and chloride rich. Do not use HES as we spoke, لأنه راح يكون عندك higher mortality و more acute renal failure. إذا بتعطي المريض كثير fluid like normal saline, you can try to give them a little bit albumin, try to decrease the amount of crystalloid that you are giving. بس again إذا الألبومين نحكي إنه غالي كمل بالنورمال سالين لأنه ما في difference بالمورتاليتي. My colleagues will be talking more about vasopressors, بس إنه راح mention quickly norepinephrine, epinephrine, dopamine. They have the inotropic effect with vasoconstriction effect. Dopamine والميرينون, they have the inotropic effect, but they are vasodilatory. Phenylephrine, vasopressin, they are more like a vasoconstrictor with no inotropic effect. Norepinephrine versus dopamine. المريض طبعنا بشوك، شو اللي نستعمله؟ هلا bottom line, norepinephrine is the first to be used in septic shock. هلا بالنسبة للدوبامين, as we see here, it has 24% arrhythmias compared to 12% بالنسبة للليفوفيب. It causes أكثر atrial fibrillation, VTAG, VFib. هذا number one. Number two, إنه the data showed that it may be associated with a little bit increase in 28-day mortality in cardiogenic and septic shock. Though, as we see here on the Kaplan-Meier curve, norepinephrine has a higher survival, but the P ratio was 0.07 which is makes it statistically insignificant. But again, levofed is or norepinephrine هو بيضلوا الدراج اوف تشويس بالسبتيك شوك. هلا بعد هيك اجى الفاسوستاتين اللي هي عباره عن norepinephrine versus norepinephrine vasopressin مع norepinephrine. البوتtom لاين لهاي الستدي انه اذا المريض عندك more severe septic shock using norepinephrine versus vasopressin with norepinephrine there was no change بالmortality rate. بس less severe septic shock with نحكي levofed requirement أقل من 15 microgram per minute divided the group 90-day mortality there was difference and they were in favor in using vasopressin in this arm. So the mortality rate was 35% compared to 46%, and that was with P ratio of 0.04. We can see here vasopressin with norepinephrine on 90-day mortality.
Dr. Muhammad, 3 more minutes.
إن شاء الله.
4 minutes of you have the second one, but we want to give you a break 5 minutes for a little bit of discussion.
إن شاء الله. The mean arterial pressure again it target 65 to 70 versus 80 to 85. التارجت راح اسرع شوي هنا انه no difference between mortality between the two arms بس the duration of pressures was higher mean arterial pressure more than 80 to 85. Atrial fibrillation with arrhythmias were higher if we are targeting higher blood pressure. Renal replacement therapy with chronic hypertension كان أكثر بالتارجت للمين ارتيريال بريشر 65 to 70. أهم شيء نتذكر إنه بدنا تارجت blood pressure 65 to 70. Steroid is adjunctive therapy for patients requiring higher dose of vasopressor, refractory septic shock, and this is a weak recommendation. As we said إنه mean arterial pressure 65 to 70 لازم نتذكر هاي وبدك تحاول to recheck on your patient, make sure mental status is stable, not getting worse, skin is warm, capillary refill, urine output is very important to remember to check, make sure انه المريض بيعمل 0.5 to 1 ml per kg per hour. برضو بدنا نركز lactic acid clearance انه اول اشي lactic acid is improving والشغله الثاني is getting worse. If it's getting worse that does not mean انه you are running behind fluid resuscitation every time. Make sure انك you are not missing another diagnosis like mesenteric ischemia, compartment syndrome, or انت بتعطي المريض medication that has side effect like epinephrine increase lactic acid او مريض اجى بأزمة وبنعطيه continuous albuterol it will increase that. فالبottom line diagnostic approach to determine type of shock management, fluid, vasoactive medication, treat the underlying cause, mechanical support as indicated, resuscitation goals. والحمد لله رب العالمين وجزاكم الله خير.